Welcome back to Fertility Fact or Fiction, the show where we reveal all the truths and bust all the myths in infertility. So tonight we are happy to be back and go over some questions with all of you. There has really not been anything amazing in the world of infertility as far as research publications recently, so we felt that we would just jump into your questions again. It's kind of funny that the pandemic has slowed down the flow of research, and so there are far less articles of interest to share with all you guys. At least the ones that I see seem to pique my interest a lot less than they used to. So nothing really exciting happening. The biggest news here in Canada is that they're going to be letting Americans cross the border, and since we are the only border town fertility center in Canada, we have some significant advantages in servicing American clients who can come to us through Detroit quite easily and save about 2/3 of the cost of what an IVF cycle costs in America. In particular, if you're looking for guaranteed IVF programs, we are way, way less expensive than they are in the US. And also drug costs, which you can purchase here and take across with you, are about 30% cheaper as well. So even if you pay duty on them going across, you're going to save yourself a bundle. So between the dollar value difference and between just the general savings, because we don't tend to gouge people, you can really have a very robust IVF cycle here. And we can still manage monitoring you in the States and just having you show up for retrievals and transfers. So that's going to be happening by mid-August. So we're really excited about that. And actually, we've already been approached by a US company that is coming to talk to us about allowing us to see patients that are insured over there because we're cheaper, and we've already spoken to them and said, yeah, we're willing to charge you less and provide better service than they're getting in the States. So let us be partners. And of course, because I'm US board certified, it's an easy fit for them because I can do it without any licensing issues as well. So kind of big news for us. We're really excited about that. Our program is growing. We're already adding an extra 2,000, 2,500 square feet of space. We were anticipating some other doctors joining us in the next little while as well. So I think it's going to be phenomenal, and the growth here has been incredible, and the outcomes here have also been incredible. So very, very exciting. Huge thanks to my amazing, amazing team who ran the place without us for about 10 days while we were away. And huge thanks to Dr. Fariba Khosravi, who is actually staying a little bit into our next holiday, which is at the first week of August, to take care of a special client who needs some extra help and assistance, despite the fact that it's her holiday. So when we say no one walks alone at VRC, we really mean it here. We really try and go above and beyond to help everybody. So I think we're going to start taking your questions straight off the hop. If not, I'll find an article and we can kind of review it. But we're going to take questions. So if you guys have questions to ask tonight, feel free to do so. I recently will just relay an anecdote. We have one very devoted follower on our program who has approached me from the US. I'm sure she's watching now, so I hope everything is going well. And she was talking to me the other day about the fact that the protocol we sent her for her frozen embryo transfer involved a lot less estrogen, and she still got the same endometrial thickness that she was getting before. So with way less pain, and she has endo. So this is like an amazing opportunity for her to get less inflammation, less endo stimulation, but still get good endometrial thickness. So estrogen really is not the best agent when you're trying to thicken the lining necessarily. Giving people tons of estrogen actually has adverse effects, and there is more and more data coming out suggesting that if your estrogen levels are really high, it can potentially be detrimental to your cycle. So I'm really glad it's working out for you. Amazing. We do frequently share our protocol. I don't keep it a secret. We went through the whole thing in detail on our last program. So jump onto YouTube, look up last week's presentation, click subscribe, and have a look because we went through it in detail there. So do you have questions?
Oh, yeah.
We have questions. All right. So we're going to take your questions. Fire away.
So this first question was on our Facebook group.
Okay.
So somebody was asking this. So they said, if I have 19 fertilized eggs and doing PGT testing, how many should I test if I have unexplained fertility?
Well, that depends on your age. So the answer to that is it could be only a few of them or all of them. So if you're young, and you probably are if you made 19 eggs, you don't need too many. Probably be reasonable to do 8. And most of the genetics companies batch their grouping of the genetic testing into 8 embryos for a kind of a bucket price. So, for example, the company we work with, Cooper Genomics, they charge us $2,200 Canadian to do up to 8 embryos. So it would make sense to just send the 8 and then you know what you've got. If you're older, then keep in mind that the percentage of embryos that are abnormal entirely depends on your age. So let's go through some examples. If you are 35, anticipate that 50% of your embryos are not going to be normal. So if you still do 8, you're going to hopefully get 4 embryos that are going to be normal, maybe 3, maybe 5, but somewhere in that range of 3 to 5, probably 4 that will be normal versus abnormal. If you're 37, 38, you're looking at 2/3 of your embryos being abnormal. So now you're looking at, out of every 3, 2/3 of them will not be normal. So you'd have to send 9 to get 3 normal embryos, which virtually guarantees you 1 live birth. If you're 40, you're now looking at 3/4. So, you kind of need 12 to get those same 3 embryos. And if you're looking at, you're over the age of 40, you're 41, 42, 43, it could be as high as 80%, 85%. So now you're really needing quite a number of embryos to test. So it entirely depends on how old you are. And that's really critical to understand. If you are young, you're under 35, I'd probably just start with the 8. Ideally, in a perfect world, if cost is not an issue for you, just do them all, because then you know which ones to use and which ones not to.
We'll go from Instagram first.
Sure.
Can you still be an egg donor if you have had your uterus removed?
Yeah, absolutely. You can be an egg donor if you've had your uterus removed. So we have patients that were born without a uterus, and we have other egg donors that have had their uterus removed for either surgical reasons or pain or fibroids or whatever the case was. So the main issues are not if you have a condition which necessitated losing your uterus that impacts fertility, for example, endometriosis or cancer. But aside from that, yeah, there's no reason why you can't. We have to be a bit more careful when we do your retrieval, because we got to make sure we don't bump into bowel or something like that on the way to the ovary. So position of the ovary is really important on ultrasound, but as long as the position is okay, or you have someone skilled in doing a transabdominal retrieval, you should be fine.
All right, 40-year-old with DOR and a high day 3 estradiol. Is there any way to bring the estradiol down?
You can try estrogen priming. That might work. You can just wait for the right cycle, but typically your estradiol levels are higher as the ovary is beginning to fail, as a function of the occasional response to the high levels of FSH, and then it starts producing estrogen. So it's kind of complicated. Various techniques you could use are, basically try a cycle of birth control and then jump into it, or wait for the right cycle, or try estrogen priming. Any of those may work. The problem with taking birth control, it'll reduce your estrogen level, but then it suppresses your ovary. So sometimes it works, sometimes it doesn't. It's not ideal, though, in that circumstance, because you don't want to get suppression and then produce even fewer eggs than you could have had you not been suppressed. That's a great question, actually. Thank you for asking that.
Do you find much of a difference in sperm quality between men who are 40 years old versus 50-year-olds?
Yes, so that's been shown. Actually, there are a lot of studies that show that as men age, and we've reviewed that on the show, miscarriage rates go up, DNA fragmentation increases, sperm quality decreases, aneuploidy rates we're not sure of, but we think increase as well. So that's the percentage of embryos that are genetically abnormal. So it's not all on the ladies for sure. The guys have to fess up to taking responsibility also. The reality is that we are equally responsible for egg quality. In fact, just before the show, and I think I still have it up, there's an article that is out which talks about the fact that, and it's just coming out, and it was one of the ones I was considering reviewing. Maybe we'll do it for next week. They looked at the fact that women who are older have poorer quality embryo outcomes when the men's sperm has DNA fragmentation, whereas when they're younger, the eggs can sometimes compensate for the fragmentation a bit. So guys do contribute to that negative egg quality. Sure, the women who are younger may be able to correct for it, but the fault is at the side of the guys to begin with. So as we age and our sperm gets poor quality, it does make a difference.
Just scrolling here. What are your thoughts on 1PN PGT tested embryos? What are the risks of transferring the risk of transferring
the embryo if it's 1PN? If
increased miscarriage risks for baby?
So in theory, and there was an article on that a while back that showed that if you grow out these abnormal PN embryos, they can't actually test genetically normal. So if they test genetically normal, you should have the same outcome. There shouldn't be an increase in miscarriage rates. So you should be fine as long as it is PGT tested and it is normal, because they shouldn't be normal if it's 1PN or 3PN. But if it is genetically normal, you've got an embryo that actually grows out and develops, it should be okay.
Thoughts on why someone with an AFC of 10 and an AMH of 1.1 would only collect 4 eggs in a retrieval? This is the second time on high doses of stims and getting less mature eggs than follicles.
So some people don't release very well. Some people have empty follicles. And sometimes it's the technique. So our policy here is that when we do the egg retrieval, depending on the number of eggs, we will use a double lumen catheter or a single lumen catheter, or needle, I should say. So let me explain the difference. In a single lumen needle, there's one needle and it's got one channel through it. So you stick the needle into the follicle, you drain the follicle, the fluid goes out through the needle into the tube. We send the tube off and we see if it's got the egg. You can flush fluid back into the follicle through that one chamber, but it's complicated and it's messy. So when we don't have a lot of eggs, and typically for us that's like 8 or less, we'll use a double lumen needle. So a double lumen needle has 2 chambers within the same needle, one for sucking the egg out, one for flushing fluid in. So I just did that this morning where we yesterday morning, where we did an egg retrieval and we flushed fluid in because I was going one by one. She only had 7 follicles to make sure we were getting every follicle. So when I didn't, so I would drain the follicle, wait for my embryologist to tell me she had an egg. If she didn't say egg, we would flush sterile culture media into the ovary, rinse out the follicle, drain it again. So one channel lets it in, one channel lets it out. That way you're kind of rinsing out the follicle. Out of the 7 eggs, I got all 7, but I would say that about 3 of them came out on first try, and the other 4 only came out after I rinsed multiple times. So rinsing the follicle out with media can sometimes help to get those extra eggs. We do use double trigger, and I think that can be helpful. And certainly the studies support double trigger for outcomes because it's better than using a single trigger. And then the other thing is, did they actually test you to make sure you met the criteria for the trigger. In other words, did they measure your LH if you used the GnRH agonist? Did they measure your HCG if you used HCG? Because that too is important if you're worried about the patient triggering. Normally, though, it's an issue of just not rinsing out the follicle because the egg has not released. The other thing is the timing of your retrieval. So this is a delicate issue. You wait too long, you can lose the egg. But if you go too early, your egg may not have detached from the wall of the ovary, from the wall of the follicle, and it may not actually be able to come out. So those are the ones where you may need to rinse several times, or maybe just delay your retrieval. If you're doing a 34-hour, wait till 35, 36. If you're doing a 36 already, you may need to wait till 37, although keep in mind they can release, so it can be touch and go with those ones.
Can we still take melatonin during pregnancy?
Yes, melatonin is totally safe during pregnancy. There's no reason to stop. It's in your body already, so you can take extra.
I am suffering a lot of pain because of multiple fibroids. I had an IUI once and it failed. I am your patient. Is it possible that I can operate and take out my fibroids? I need help.
Well, it's certainly not possible that you can operate, but I can certainly operate for you. Yeah, of course, we can take out your fibroids, resolve the pain, and then reapproach the whole fertility issue. That's not a problem. The only time that is difficult is if you've previously had severe endo, or you've previously had fibroids removed and there's so much scarring that it's not possible. But as long as it's what we would call a virgin pelvis, no one's ever done anything in there before, you don't have bad endometriosis, there's no reason why we can't take out the fibroids and then reapproach the whole process of whether or not we take the eggs.
You got a question in your direct message.
Oh, do I need to look that one up? All right. Someone said to you that they direct messaged me?
Yeah.
Do you want to give me some initials?
L, UCI.
UCI.
It's right out here.
Oh, okay, got it. Okay. I couldn't submit my question on chat for some reason. Here it is. Just turned 38, 2 natural miscarriages in 2020. I'm sorry. Male factor, and earlier this year was also diagnosed with DOR, failed Clomid challenge, very high FSH, low AMH. Okay. No endo and no PCOS. I changed my diet and took supplements, and in June got my FSH down to 9. But first IVF turned to IUI because I only had 2 follicles. This month, my FSH was at an all-time high 43. I didn't realize it could vary that much. Are donor eggs my only option? Oh, P.S. I'm also looking for a new clinic, so maybe I'll see you in Ontario. Okay, so that's a fabulous question, and thank you for asking. The answer to that is donor egg is never your only option. There's always a way to make you produce eggs. I shouldn't say always. In the vast majority of cases, there are ways to make you produce eggs. Here are the factors that you need to consider, and these are really important. So number one, if your FSH is high, your AMH is low, and your FSH is 43, the likelihood you will produce more than 1 or 2 eggs is extremely, extremely low. So your best bet is don't take a ton of medication, don't do a lot of stimulation, just do natural cycle IVF and make sure they charge you way less, because we do. So you can just do natural cycle IVF. Maybe you have to do it a couple of times, but you'll get a couple of eggs altogether, hopefully a couple of embryos. You send them for the PGT testing. If you have some that are normal, you've avoided the donor and you have a decent chance of success. If you don't get any that are normal, then you know you need donor eggs. So that's a very reasonable entry-level approach. That's one thing you can try. The other thing you can try is PRP. There is one study and one study only that suggests that injecting PRP into your ovary may improve the function of the ovary and bring down that very high FSH and bring up the AMH a little bit. What does it result in? That study showed an 0.3% success rate overall in live birth. So, I mean, that's terrible, but it's better than 0. So if you're willing to do all of the steps that are necessary to make it work, and one of them is doing a PRP injection into your ovary, it's a reasonable approach. And if you go somewhere reasonable, it shouldn't cost a fortune. We're just about to set it up. So I will be doing it shortly with a nearby partner, actually an aesthetic clinic that can move around their centrifuge for PRP. So we might do it and start using it, but it's a whole other level of involvement. So that's something to consider if you want to try it that way. The flip side of this is, what is the quality of what you're getting, and how many tries, and how much is this all going to cost, and what's necessary? So if your AMH is 43, the quality of your eggs will be compromised. No matter what you do, no matter what supplements you take, no matter what you see on the internet, you will have compromise in your egg quality. So the chance that the eggs are A, energy efficient, and B, genetically normal is going to be significantly reduced. And we've reviewed that on the show about 2 or 3 months ago, where we went through a study that demonstrated that women with weaker ovaries do have a higher chance of having genetically abnormal embryos. So the problem for you is, regardless of your age, you're only 38, like you said, your ovaries sound like they're acting like you're more like you're 45 plus. And that's not to disparage you in any way. It's just the biology of your ovaries. So in that circumstance, you have to understand that over 90% of your embryos will be genetically not normal. So that means you would need like 10 embryos to get one that's genetically normal. So it could involve a lot of tries before you get to that one that you find that's normal. Now, maybe you're lucky and it happens on first try. Maybe you're not lucky and it takes all 10 tries and you still don't have a normal embryo. So that is a complicated part of this. The other thing that you have to factor in is it will take multiple tries, in which case that's multiple needle pokes, multiple bouts of some medication, even if you're doing natural cycle, limited with us, but nevertheless, some meds are necessary. And then there's the cost of all the PGT testing, all the IVF cycles. Even if it's natural cycle, it's still going to add up. So there are genetic components to this in terms of your outcomes, number of times you need to try. There are cost elements to this. There's the need for PGTA. So all of those things are imperative. As far as the donor part is concerned, of course, it's much easier, but that's a personal choice. Some people are not comfortable using donors. So if you're not comfortable using a donor, by all means, we're happy to help you. You just have to know exactly what you're getting into. And I spell that out for all my patients. So if you'd like to become our patient, we're happy to help you out, but I will never lie to you. I will never tell you, oh yeah, you should try this if I think genuinely it's not going to work. I will tell you exactly what I just said. You may have a very low percentage chance, 5%, 10%, whatever the percentage is. If that's enough for you to give it a shot, I will back you 100% and I will do my best to make it work. If it's not, then for God's sakes, don't do it, because I don't want to be the guy that takes money and does something that doesn't work or that you're not comfortable doing. I will never do that. Great question. There was another one there too. You want me to look at that one also?
Yeah, sure.
Try another?
Go for it.
All right, let's see what the other one was.
I couldn't answer that question, so I felt it was good.
Okay, here's my question. Here's another watcher. We have our first appointment with you next month. In the welcome information we got from you, you recommend a list of vitamins. Is it too soon to start taking them now? I've already been taking most anyways, but the melatonin aspirin I have not. Thank you. So the answer is yes, take the melatonin. That's been shown to have a significant increase in success. And aspirin, I'm a big believer in. So yes, take the aspirin as long as you don't have any contraindications, especially if you're a smoker or steroid user. That'll rot a hole through your stomach as fast as possible. So I believe in those. And if you're already taking the other vitamins or considering listening to us and taking the other vitamins, by all means, take them before you see us, because it can take months for these vitamins to undo the damage your body may have already experienced. So for sure, the sooner you start them, the better off you are.
What are your thoughts on duo-stim for patients with DOR and low AFC?
It's great. I mean, there are multiple studies now that show that it is beneficial. It was designed for people that meet the Bologna criteria, and most of the studies show that the embryo quality you get from the second stim is actually better than the first. And they also show that, the pregnancy rates are actually quite reasonable. So we're big believers in duo-stim. I right before the show was setting one up for a patient that actually had great ovaries, but for some strange reason just wasn't responding the way she should be. So we actually said, look, we'll flip you to a duostem. You've got a whole bunch of eggs that are catching up. So we're going to do that for her and flip her from just a single normal cycle to a duostem cycle. Even though she doesn't meet the criteria, we like to help people out. So we individualize all the time. So yeah, I think for those patients, it's great. There's no question that the science supports that, in particular for women with DOR. So yeah, I mean, we see a benefit to it, and we offer it to those patients. It's in the packages that we offer. Our fact or fiction on that was like a year and a half ago. That was a long time ago. It was one of the ones we did at the desk, yeah, at the island. So have a look at that. And see, if you want to do it, but there's very good evidence that supports doing it for sure.
How long does it take for combined NT results?
About 2 weeks for us to get the results. Yeah.
I have had 2 IUIs. Do I still need to do one more IUI before I can enroll in the funded IVF waitlist?
With us, yes, because otherwise the wait list is unmanageable. And by the way, it's already unmanageable. So we do not recommend that any of our patients factor on the wait list. I actually encourage people to consider registering with other clinics because no matter where you go, it's like a several year wait to get a funded IVF cycle in Ontario. We are still hopeful that the government is going to consider funding our program. If any of the lovely members of Premier Ford's cabinet are watching, we need funding. So please help us out if you can. And for those of you that want funding for Windsor, whether you're from Windsor or not, because you don't have to actually be in Windsor to get funding from Windsor, write to the Premier's cabinet, write to everybody there, write to the health minister, write to your MPP, tell them we need funding for the Windsor program and get them on board with that.
Taking CoQ10,
okay,
NAC,
yeah,
melatonin, should these be taken during the entire IVF process? Should they be continued if you do get pregnant?
All 3 of those are fine to continue while you're pregnant. So yeah, just take them the whole time.
Got a huge one.
Okay.
Okay. It's the biggest question I've ever read to you.
Do you want me to do it or do you want to do it?
No, I'll do it.
Okay.
Get ready.
I'm ready. Fire.
Hi, Dr. Victor.
Okay.
I have a question that relates to IVF patients on long-term use years of inhaled
Corticosteroids?
Corticosteroids. Yes,
okay.
Very good. For conditions such as asthma, do you ever assess patients' serum DHEAS levels, and more specifically, patients using inhaled corticosteroids and or patients with DOR, POR? Should a patient in that situation request a blood test for serum DHEA? Do you ever recommend DHEA supplementation for these patients or in any circumstance? This question is based on research that shows inhaled corticosteroids uses decreased serum DHEAS concentrations and can lead to adrenal suppression, low DHEAS, has been found in women with impaired lung function.
Wow.
There is some evidence that DHEA supplementation improves IVF outcomes and ovarian reserve markers for women with diminished ovarian reserves, poor ovarian responders, particularly those with low DHEAS levels.
So we measure DHEAS levels in all our patients. We always have, and we always will. So I am aware of the importance of DHEAS. As far as the corticosteroid element, you would probably need to be on a hell of a lot of inhaled corticosteroids to suppress your DHEAS levels. Nevertheless, if you're suppressed, I would actually start by seeing if there was a way to get you off of the inhaled corticosteroids onto something else. And that would be a reasonable approach. If that wasn't possible, sure, we could supplement with DHEA. Does DHEA work? Well, we just reviewed that on the show a few weeks ago, and it does appear to be beneficial. So there is some evidence from multiple different studies now, in particular one meta-analysis that we reviewed, that suggests that DHEA does provide an increase in live birth. It constantly goes back and forth. So there are some studies that have shown it does not, and for the longest time it didn't. And then now there are enough conglomerate studies that when you pool them all together in a meta-analysis, it does appear to be providing some benefit. So we do use DHEA to supplement our patients. I think it's a reasonable approach for you. And certainly if you are suppressed from corticosteroid use, it may be a reasonable approach. However, if you're that suppressed, there's probably other suppression effects from the corticosteroids. So I would ideally work with your respirologist to see if there was a way to get you off of that much, put you on some other more stable regimen so that we don't have to worry about all the impacts of the steroids on your overall reproductive function.
As part of your protocol, I was prescribed antibiotics prior to implant. We lost the pregnancy and have done the Fertilisers package and waiting for results. Is it true that bacteria is commonly found?
So there is normal bacteria and there is abnormal bacteria, or even normal concentrations of certain bacteria and abnormal concentrations of other bacteria. So there's always bacteria present in the uterus. The question is it the right mix, and what mix is ideal in the vagina and in the uterus in order to help achieve pregnancy? So there is data on that. It's called the vaginal or the uterine microbiome. And that data suggests that if your balance of good bacteria, I won't go through them all, but to bad bacteria is off, that your chances are drastically decreased. So yes, there's always bacteria because there's supposed to be, but frequently there are bad bacteria. Is it the cause of miscarriage? I actually firmly believe it is one of the causes of miscarriage. But is it always the case? No, certainly not. And you could have miscarried for a variety of different reasons. I'm sorry that you did, by the way, that's terrible. But it can happen. And the Fertilisers testing for us is useful in those cases because we get to figure out what's going on.
If you're doing a PGTA testing and dual stim, are the biopsies from each cycle sent to the lab separately or altogether after both cycles?
You can keep them for a short period of time before you send them to the lab, but we send them in 2 batches just to make sure the lab gets them so we don't worry. And we don't charge you extra for the fact that we're shipping them twice, but there are 2 biopsies. So we don't charge the full amount of 2 biopsies. We have a separate PGTA package within the DuoStim. We tried to bring the prices down to help everybody because these are the patients that need the most help. So we've reduced the costs for everything. And that's the scale for all the stuff that we do. So for example, if you're doing natural IVF, a natural cycle IVF, our cost for a biopsy is much lower when we're just doing 1 egg, 1 embryo, than it is when we have to do dozens. So we've scaled everything to fit each package so that we can save our patients as much money and resources as possible. For us, it's very much not about the money. I've gone out of my way my whole career to try and make it affordable for people. We've done everything we can to manage, including doing free IVF at times. So we will go out of our way to always make this as accessible to all the people that need it as possible. And as part of that, it's saying, hey, if they're already paying more for their cycle, maybe we should reduce what they have to pay for the PGT down as much as humanly possible for us. And that's what we've done.
Is there a way to naturally delay ovulation? I normally ovulate on day 10 to 12 and know that's very fast. I'll prescribe estradiol, but wondering if there is something I can do naturally.
No, don't take estradiol. Just take letrozole or Clomid. Normally on letrozole or Clomid, you'll delay till about day 16, 17. So that's easy. Yeah.
I've heard that 1 to 3 Brazil nuts a day can help FET implantation rates and prevent miscarriage because of the selenium in them. Is this correct?
I have never heard of that before in my entire life, but that sounds good enough to look up on the show. IVF and Brazil nuts. Nothing. Let's look up FET and Brazil nuts. Nope. FET and nuts. God, I hope it doesn't pull up porn. Dietary pattern characterization among subfertile South Asian women and the impact of vitamin B12 intake. Wow. Main results, 4 components contributing to overall variance, namely meat, poultry, and seafood, green leafy vegetables, and root tubers, fruit, blah, 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 blah. So these guys were focused on B12. This does not help us at all. So let's look up FET and selenium. I mean, I guess my question would be, why not just take selenium? Nope, nothing there. Let's look up IVF and selenium. Someone must have looked at that. Yep, there's data for this, looking at male reproductive outcomes and female, although more male. It's mostly related to sperm quality. So you can look at it. The Cochrane database has an updated review of what antioxidants can help improve your fertility. It was done in 2020. Antioxidants for female subfertility. And I think if I remember when I read it before, it said they didn't know enough. Here's their review. They look at a whole bunch of different antioxidants. Here's what they said. In this review, there was low to very low quality evidence to show that taking an antioxidant may benefit subfertile women. Overall, there is no evidence of increased risk of miscarriage, multiple births, GI effects, or ectopic pregnancies, but evidence was of very low quality. At this time, there is limited evidence in support of supplemental oral antioxidants for subfertile women. So that's from their study. Maybe we should review that one next time. They looked at everything, a whole bunch of stuff, and included 63 trials. So there you go.
What's the age cutoff to be an egg donor?
Well, there isn't an age cutoff to be an egg donor, because if you are coming in here and you have a 36-year-old sister and she's willing to be your donor and she's healthy, of course I'm going to take your sister, so that A, you don't have to pay a fortune for a donor, and B, you get 25% shared genetic homology with your child. So we don't specifically have an age cutoff. Now, would I take a 40-year-old sister? Probably not. I'd probably say 36, 37 would be my cutoff. But for an anonymous or a non-related egg donor, we are ideally looking for 21 to 28. We will occasionally make exceptions if the donor is really, really good and go into the early 30s, 31, 32, maximum 33. I would never go beyond that, and you got to be pretty damn amazing at 33 for me to be willing to consider it.
What can men do about sperm DNA fragmentation?
Don't drink, don't smoke, don't use drugs. And when I say don't, I mean don't, like zero. Keep your testicles cool, so sit on frozen peas. Do not wear tight underwear. Ejaculate every 2 days. Take bucket loads of vitamins. If you're overweight, lose weight. If you're underweight, gain a few. Exercise daily, meditate, pray. What else has been shown to be beneficial? That's pretty much it. Avoid, chemicals, toxins. Don't drink out of plastic bottles. All of that stuff's really important.
Should vitamin E be taken into preparation for an FET? Should it be discontinued after transfer?
You don't need to discontinue after transfer. Vitamin E has been shown to thicken the lining, so if you need it, take it.
Can you walk us through gestational diabetes, what causes it, and how it can be treated?
Okay, so gestational diabetes is caused by antagonism from something called human placental lactogen, which is a hormone produced by your placenta, with insulin and glucagon in your maternal system, therefore making your body more resistant to your own insulin And because you're more resistant to your insulin, you become diabetic, so your sugar levels go up. Insulin drives sugar into your cells. And when the insulin is not being responded to, the sugar in your bloodstream is not going into the cell. So when we measure it in your blood, it's really high because it's all floating around in your blood instead of actually going in the cell where you can't measure it. So that's what gestational diabetes is. In order to treat it, it starts normally with diet changes. So number one, let's back up. To avoid it, don't go into your pregnancy overweight or obese in particular, if you can avoid that. So get healthy before you get pregnant. And if you are already pregnant, then don't gain a lot of weight while you're pregnant. I'm Middle Eastern. Tarek's Middle Eastern. So in our culture, the minute you're pregnant, every member of the family gets an automatic medical degree and tells you need to pig out for the next 9 months. That is categorically not true. In fact, it's very detrimental. So you need to eat a healthy, balanced diet and not pig out, because you don't need to become obese in order to have a healthy baby. And really chubby 10-pound babies are not cute, because when they grow up, they have diabetes, high blood pressure, heart disease, higher risk of cancer, all sorts of things. So you want to have a healthy, balanced diet. Do not gain too much weight. If you, despite all of that, still have gestational diabetes, it starts with diet control and monitoring of your sugars carefully. If that doesn't work, the next step is to do insulin. And frequently for us, we keep many of our patients on metformin, especially the PCO patients, right through the whole pregnancy, because it does probably cut down on their incidence of of gestational diabetes. So you can use oral meds. It's not big in Canada, but they do it in the US. You can definitely use insulin. And then your other option is to do, the diet control. So that's pretty much everything there is on gestational diabetes. Now, is it risky for you? No, not at all. Other than that, after the pregnancy, you're at a 50% lifetime risk of developing type 2 diabetes. Is it risky for the baby? It can be. If the baby gets too heavy, then the shoulders can get stuck, which is an all-out disaster. The sugars of the baby can be quite low after it's born, so it needs sugar monitoring. It may need to be in the intensive care unit. And babies that are born to moms that are diabetic have higher risks of having diabetes, heart disease, high blood pressure, and so on when they grow up to become adults or even children.
Hi, Dr. V. I've read lots online about AMH.
Okay.
Is 7.7 picomoles considered low? I'm 31, 3 consecutive losses, 17-week, 2 chemicals. I'm wondering if poor egg quality could be playing a factor.
So first of all, I'm very sorry for what you're going through. There is probably nothing worse than one of those second trimester losses. They're horrible, especially for infertile patients. So my heart goes out to you. I'm sorry for what you're going through. So it sounds like egg quality could be a factor there. An AMH of 7.7, no one considers that low, but it's on the lower side. And certainly at 31, that is definitely on the lower side. So we wouldn't normally associate that with a situation where there's multiple miscarriages and 17-week loss. You should really be seeing one of us to get a comprehensive recurrent pregnancy loss workup. But could that be part of what's going on, that it's egg quality? Yeah, of course it could be. Is your AMH reflecting that? A little bit, but I'd be much more worried if you were like a 2 or 3 at 31 or any number under 5 than I am with a 7.7. It's still a reasonable AMH.
Now that we're in stage 3, will you be doing in-person appointments rather than over the phone?
We are open to doing in-person appointments for anybody that wants them. We have found that patients actually many of them prefer being online or at home just because it's convenient. They don't have to come in. But I like seeing people. So if you want to come in, by all means, I'm happy to see you. We've recently been getting feedback from our patients that they prefer more Zoom calls rather than just phone calls. So we're offering that to everybody as well. Look, I'm here. I sit in my office or I go to one of the exam rooms. It makes no difference to me. I'm happy going wherever. I do like talking to people and seeing people. it's always nice to put a face to a name. So by all means, if you want to see us in person, we're happy to see you.
Is it normal to not feel pregnant anymore at 14 weeks? All previous symptoms just went away.
Yep. So nausea, vomiting right at 14 weeks tends to plummet. And breast tenderness by that point should be good. The only symptom you may still have, which again is a bit better at that point in the pregnancy, is needing to pee frequently, urinate frequently. So you should be feeling very few symptoms now.
How important is the desired 8 millimeter uterine lining when doing an FAT? If you don't reach 8 millimeters, you usually cancel that cycle and try again with a different protocol? Thanks.
It's important if it's less than 8 millimeters. A thin lining, which has been poorly defined, some people would say less than 8, less than 7, less than 6, has been associated with decreased success in multiple studies. Thicker than 8 has also been associated with poorer outcomes. But around that level of 8, 9, like 10 is probably kind of the sweet spot of where you want it. So that's what we aim for. If you're much thinner, and I haven't tried other approaches, then I would not transfer. If you are much thinner and I've tried multiple other approaches, then it's up to you. We got to have a long discussion of, do you want to consider a surrogate or do you want to try in you with a thin lining? And that is the one and only time that I actually will offer patients an ERA test, because if they say it's receptive, I don't care about the timing. I just want to know if the genes indicate receptivity. If they say it's receptive, you may have a chance of making it work. Prime example, I had a beautiful lady with a genetic problem who only ended up with one genetically normal embryo. So we needed to make this work. So I started her stim for her FET, could not get it more than like 3.5, 4 millimeters. Did everything you can possibly imagine. We tried vitamin E, we tried Viagra, we tried vaginal, we tried oral, we tried, you name it, we tried everything. We even tried stimulating her to, like with Gonal-F and Menopur, to see if we could get the lining to grow. Nada, nothing, could not get it to grow. So finally I said, let's just do an ERA test and see what it shows. So the ERA test actually showed that she was receptive. Ignore the time, the timing from ERA is meaningless, it doesn't work. But it did say she was receptive. So because it said she was receptive, I said, well, this is saying it's doable. Do you want a surrogate? She said, absolutely not. I said, well, let's try it. So we got her ready. We put in the embryo, turned into a beautiful baby, just like mommy. So it worked out great. So that's the one and only time that I'll use an ERA. Otherwise, that test is useless. Please do not do ERAs. So if your lining's really thin, we don't do it. We really aggressively try to avoid it. We have been using a fair amount of this new technology from a product called Matris, M-A-T-R-I-S, which does not require anything too fancy. It's an ultrasound. We're actually going to probably integrate it into our practice, at least for a little while. So I'm not even going to charge you guys for it because we negotiate with the company to hopefully make it doable for us. So we're going to eat the cost and add it in. If your Matris score is low, we won't transfer you. If your Matris score is good, then we will. I will tell you that doing what we do with our protocol, all the patients that we thought should not be transferred, Matris agreed with. And all the patients that we thought should be transferred, Matris agreed with. So I'm using it to verify that our protocol works and kind of gauge where the fallout is. Because if the Matris works and suggests that things are good, it kind of eliminates the endometrium from being part of the problem. So we are playing with that technology to see if that helps. It does have requirements for endometrial thickness. We don't know what they are because it's proprietary to the company. But of course, the thickness of the lining is going to play a role.
AHA and ubiquinol help with egg quality. AFC 7, AMH 7.7 picomoles, age 35. What would be the IVF protocol for miscarriages 6 weeks?
Wow. Okay, so first of all, if you've had 4 miscarriages, again, I'm very sorry. That's awful. So the first question is, why are you miscarrying so much? And before I would even touch you with IVF, I would want a full comprehensive review of the miscarriage problem, because there's no point in doing IVF if you're going to miscarry a genetically normal pregnancy. So you need a complete recurrent pregnancy loss workup. So that's step one. Before you spend a penny on IVF, make sure they figured out how to keep you pregnant once they get you the right embryo. From the standpoint of DHEA and ubiquinol, DHEA definitely does not improve egg quality. It may help your live birth, probably by making you make more eggs, but it does not help embryo quality. That has not been supported by any data as far as I'm aware. Maybe a smidgen in some studies where they said you got more blastocysts or whatever, but overall it doesn't. There's no suggestion it's improving egg quality. Ubiquinol, it might, although it takes a hell of a long time to do so. So you're supposed to take it for 6 months to see a difference. No one ever does that. So that's an option, but whether or not it's improving egg quality in the shorter time frames we typically use it for, nobody knows. Okay, so that's DHEA, that's ubiquinol. The rest of it is, what protocol would I use? So if your AMH is lower and your antral follicle count is lower, I would first talk to you about the fact that you may need duostem. We typically use Lupron Flare just because I like it. And we would try and get as many eggs as we could from a Lupron Flare. We'll use like a medium dose of gonadotropins. I don't believe in bashing people with them, but I also don't go super low dose either. We would wait till your eggs are ready, trigger when you had 2 that are like 18, 19, maybe even 17. And then if there were extra eggs left over we thought we could capture with duostem, we would do the duostem cycle for you and do it again. I would do ICSI for all your eggs. I would grow them till day 5 or 6, do the biopsies for PGT, because if your ovaries are weaker, you should do PGT. And then we would see what it shows. If you get enough genetically normal eggs, hallelujah, you've made it. And if not, then it's a question of, do you try again or do you go to donor? We use lots of vitamins and supplements, so that was like the extremely simplified version of this. I'm a big believer in naturopathy. We're going to be starting IV vitamin infusion soon. So there's lots of things that can be done to improve your chances aside from just the IVF protocol. But that's like the most basic version of it. We do, as I said, use lots of vitamins, lots of supplements, healthy diet, weight control. There are many elements to our protocol. I don't just throw people into the IVF grinder and expect to get good results. It doesn't work.
I'm going to be starting progesterone suppositories in preparation for an FET. Do you have any advice for how to correctly insert them and prevent leaking?
So almost every progesterone product has leaking associated with it because the vehicle, which is what's carrying the progesterone, will liquefy and come out. Crinone's probably the one exception where it doesn't liquefy, but it turns into that nasty gel, like gooey stuff. If you're using prometrium, you're going to have discharge because the vehicle melts. The progesterone gets absorbed through the walls of the vagina, which, by the way, are probably one of the most absorptive surfaces in your entire body. So they get absorbed quickly, and then the vehicle is supposed to come out. So that's fine. Same thing with endometriosis, which has that horrible gush of fluid, although it is great product. So any of those can work and give you a reasonable outcome. You don't need to worry about how far you insert it or whatever. Of course, some of them have applicators, other ones do not. But if you take, so the average vagina is going to be like 3-4 inches long or deep. So, if you take your 2 fingers and you've got reasonably long fingers, I don't have a measuring tape, but I'm assuming my finger's about 3 inches, right? So if you can insert that to the tip of your fingers all the way in flush with the rest of your hand, then the base of your fingers, you're good. Like it's in way far enough. It's a local bloodstream effect. So you don't even need to go that far. The vaginal walls are going to pick it up, take it into the bloodstream, and away it goes. So that's all you really need. It's not like it's going directly into the uterus. It's being absorbed by the walls of the vagina and then going where it needs to go locally.
What fertility test do you typically prescribe after a miscarriage? Once I have the results, should I book a consultation with the fertilist directly? My doctor does not seem interested in the results.
So we use the menstrual or what is it called? Menstrual blood test, and they have like a bunch of different names now. So I got to talk to the guy that directs it and figure out which ones are which, because they changed the names, but they didn't outline what's what. So their website suddenly became far less clear. So he normally recommends the one that's called Full, and I think it's 420 euros now. So that's a reasonable option to use. If we're doing reproductive immunology testing, they have 2 panels for that, and so we normally order the 2 panels. With regards to when do I do it? Not after just one miscarriage. I mean, it depends on what the reason for the miscarriage was. If you have one unexplained miscarriage, 1 out of 6 pregnancies is going to result in a miscarriage. There's absolutely no reason to do anything unless, you know, there's an emotional reason or a financial reason or a medical reason that indicates it. But generally speaking, unfortunately, miscarriages are extremely common. So you don't need to go doing 1,000 tests that cost a lot of money for just one miscarriage, because chances are excellent that if you just try again, you'd have a perfectly happy, healthy pregnancy. If it's been multiple miscarriages, yeah, for sure, I would do the testing.
What are your thoughts on pelvic floor therapy to help with endometriosis pain?
There are studies that support it. I think you're going to get much better outcomes from doing your therapy via medication, like hormonal suppression. But some people get a benefit from it, so there's nothing wrong with doing that.
About to go for my FET soon. Can we walk us through what to expect the day of? How long does it take, and can partners come?
With us, partners can come. So what happens? You get here, we check you in, we make sure that everything's okay. When your time comes up, about 5 minutes or so beforehand, we will take you from our pre-FET area into the OR. We hop you on our insanely expensive, very comfortable OR chair, and we position you. I will then come in when you're appropriately covered and everything looks good. My embryologist will check your name, your ID, make sure your embryo links up to you, tell you how many she thought and what happened with them. And then I will come in. I will then check your bladder. So sometimes you're just right. Sometimes you're not full enough. Sometimes you're way too full. That's kind of more of the sometimes we experience. So we may send you to the bathroom a couple of times. Eventually, I set up the ultrasound so that we have the clearest, sharpest picture, and your bladder is in the right spot and your uterus is in the right position. From there, I step out, I scrub, I come back in. So scrub, washing my hands. I come back in, I glove, we insert a speculum. We open the speculum only the minimal amount necessary to be able to kind of hug your cervix. And then I spend a lot of time cleaning your cervix. So mucus is not embryo friendly, so we want to get rid of all the mucus. So we clean up all the mucus, we get rid of all of the mucus, and then I put the outer catheter in and I watch it on ultrasound. Assuming I can get it to the right position, you're not cramping very much. I then say, ready. Dr. Khosravi will then bring in the embryos. I will guide her to where the embryo needs to go with the ultrasound. Say, inject there, she injects, and then she takes it out. And I take out the catheter, and I actually always remove the speculum to maximize your comfort. And then she checks the inner catheter to make sure the embryo has been discharged. And then she actually even checks the outer catheter, which is probably massive overkill, but she likes to do it to make sure that the embryo isn't stuck in there. As long as we don't see any embryo anywhere, you're good to go. We keep you there for about 10 or 15 minutes. Then you go to our chair. You can either stay for a little longer or you can change and leave. At that point, you're good to go. That's it.
Okay. Does acupuncture help with DOR?
There is no data to support that acupuncture helps with DOR. However, if you speak to traditional Chinese medicine, TCM specialists, they will tell you that they see improved outcomes. So I don't know, is the answer to that. I tend to believe naturopathy and traditional Chinese medicine quite a bit. Are they going to take someone who's got terrible ovaries and make them great? No. But could they maybe get you from making only one egg to making 2 or 3? Yeah. Do we see that? Sometimes. So it's worth a try. It certainly has no downside, so it's worth trying.
40-year-olds with DOR, AFC 5 to 6, would I benefit from a mini IVF or dual stim? Would you recommend minimal stimulation dual stim? Would you recommend HGH?
Okay, so HGH does now seem to help. DHEA seems to help. Duostim, we definitely know helps. So all of those are reasonable approaches. Mini stim does not help or hurt. It doesn't make or break you. There is only one study I'm aware of, which actually just came out recently, which seems to suggest, and it's the first time I've seen this, that high-dose protocols in women with poor ovaries may result in less egg quality. So we still use a high-dose protocol, but I am considering trying low-dose. Having said that, I have done it before. It doesn't work as well. So they keep saying you get the same outcome with a low-dose that you do with a high-dose, but it's just not true in my hands, maybe in somebody else's hands. But when we do it, we get more eggs when we do a high-dose protocol. So I'm leery on that part. Mini stim I don't love. I've never understood the value of doing mini stim, but it's an option. Certainly the coenzyme Q10, the duostim, the DHEA, the human growth hormone, those are all things that can help you, yeah.
Does diminished ovarian reserve mean you also have poor egg quality? Some doctors say egg quality is related to biological age of a patient, but I can't help but think I also means poor egg quality as well.
It does.
37, but my AMH is that of someone in their 40s.
Yeah, unfortunately it does. So we reviewed a study, I think 6 weeks ago, 2 months ago, which showed that if your ovarian reserve was lower,
Okay.
why are we off the mic?
You need a battery real quick. it cut out this second. About to go for my FET soon. Can you walk us through what to expect the day of and how long does it take? Oh, we did that. Okay.
Yeah.
Thanks for answering my question. Okay. What are the options for a woman with minimal uterine lining and trying to conceive and PCOS?
Okay, so minimum uterine lining, PCOS is a different story. We got loads of videos on PCO, so you can look that up easily. Minimum uterine lining, you need my batteries?
Yeah.
Oh, here, dude, I'll just give it to you. So minimum uterine lining involves various approaches. So you can try vaginal estrogen, you can try oral estrogen, you can try both. You can try vitamin E, you can try Viagra, you can try PRP. These are all things that have some evidence for their effect. You can try just another cycle. You can try natural cycle. In a worst case scenario, you can try a stimulated cycle, which is like literally gonal-F menopause, that kind of thing. So that's reasonable as well. Those are really the main things you can try. There isn't a lot more that will work. Now, if your PCOS comes with severe obesity, that can have hormonal effects, so it may be prudent to lose weight. If you're thin PCOS, you may actually need to gain some weight. So there are different approaches to this. Can you hear those cicadas? That's crazy. Yeah. I don't know if you guys can hear cicadas where you are, but man, those things are loud. It's crazy. One or two more? Do we have any more?
Yeah, you got
it goes on forever.
Yeah, you got a lot.
All right, one or two more.
Okay. This part here, there was no sound for the second part of the answer, please. Does diminished ovarian reserve mean you also have poor egg quality? This question here, just real quick.
Okay, so did they hear the other one I just said?
They heard the other one, yeah.
Okay.
Going previously, yeah.
Okay. So if you have diminished ovarian reserve, then your embryo quality is going to be compromised. Your egg quality and thus your embryo quality will be compromised. So we reviewed this on the show, I think about 2 months ago or so, where we reviewed an article that looked at the genetics of embryos from women that had various levels of ovarian reserve. So even if you're a younger patient but have diminished ovarian reserve, your embryos have a higher chance of being aneuploid. So as a result, yes, you do need to be more cautious with your eggs and your egg quality and your embryo quality if you have diminished ovarian reserve, because simply being young is not enough to correct for the fact that the ovarian reserve is reflective of an ovary that's not functioning like someone is young. So unfortunately, yes, you do have a higher chance of poor embryo quality and specifically genetics when your ovarian reserve is low despite your age.
How does low weight in a male affect his sperm?
Low weight in a male? I've never seen anything that says that low weight in a male would affect his sperm. Low weight in a male is extremely uncommon. So it's a very rare thing to see. Now, certainly if you've annihilated all your body fat because you're a long distance runner or something, and there are blood flow issues, there's some hormones and vitamins and so on that are stored in your fat. So if you're not getting enough, that's a different story. But generally speaking, a low weight male should not affect the sperm quality. Low weight female has a huge impact on all sorts of aspects of fertility. But low weight male, I'm not aware of anything that says that it's a significant negative. Unless you're suppressed. Like obviously if your weight's so low that you've got hormonal suppression, then you're not going to produce sperm. So that's a different story altogether. Like bodybuilders, I mean, for them, it's a different reason. They're taking testosterone, but if you, without taking testosterone, were so into it that you had suppressed your FSH and LH somehow, then yeah, you're not going to make sperm.
Hi, Dr. Rahi. You mentioned last week that you use vaginal probiotics in your FET protocol.
Yep.
When do you typically start and stop them in the cycle and in the relation to PIO?
We typically start your antibiotics at the start of your stim for like when you take your letrozole, for example, and then we start the probiotics right after you've done your antibiotics. So like 5 days after you've started your stim with us. So like day 3 to 8, you'll take your antibiotics, and then day 8 till whatever, 12, 13, you'll take your probiotics, and then on into the embryo transfer. So we'll continue the probiotics. It's like a 10-day supply.
Hi, Dr. V. How many follicles during stims is considered a good outcome? Stim success, 32-year-old female.
Well, sometimes just one if that one works. But I guess the technical answer is there are some studies that say that the ideal number of eggs to produce is 12 to 15. So that's probably the number most people will quote to you. So if you can get 12 to 15, you've done very, very well. Again, it depends on age. If you're 45 and you make 12 eggs, it's probably not enough to even get one genetically normal embryo. So that's not a great cycle. If you're 25 and you made 15, you're going to have way more embryos than you need. So age is a huge factor.
Would you recommend being referred to you? Current OB has run me through all the fertility tests and HSG, all normal, 3 miscarriages in 10 months.
Oh, wow. That's a really narcissistic thing for me to answer, but yes. I would say you should be referred to me. 3 miscarriages in 10 months would be highly irregular. I need to figure out what's going on. So that's really outside of the realm of what most OBGYNs would do. That's really like generalist OBGYNs. That's more of a fertility specialist. Myself, Dr. Pattinson, if you're in town here, absolutely, we'd be happy to take care of you and evaluate. And yeah, my heart goes out to you. I'm sorry you've gone through that. That's terrible.
Do you ever have testosterone to prime? If yes, which stimulation would you think that would be best for?
We use testosterone priming all the time. I like testosterone priming. It's short and it's easy. And there is some data that supports it. There's probably more data to support DHEA now than there is testosterone. So we might be switching back to DHEA. I'm looking at that right now. And which protocol do we use it for? Any protocol where there's DOR. So if there's diminished ovarian reserve, that's where you want to do it.
I'm going to do one more.
Tarek's terminal question.
Yeah, from Instagram. So there's stuff there. It's an abyss of questions.
It's an abyss of questions. Thank you for your abyss. I do have one comment after this question. So
here's a really good one, actually.
Okay.
Which articles do you recommend to read to have a foundational understanding of fertility?
Wow. So go to the ASRM. You probably have to become a member. ASRM, American Society of Reproductive Medicine, has guidelines. Reading through those guidelines will give you a good understanding of what's real and what's not real, because those guys are not beholden to any companies. So they're just publishing science. So if something doesn't work, they don't support it, or at least they say they don't know whether or not it works. So that's a reasonable place. There is no single article to read that will give you an overview of fertility. Maybe we need one on our website. That's actually an interesting idea. It would be a gigantic article, right? Because like it's not enough to just say it's this, or the other thing. I'll say this really quickly. We have a video on female infertility. What is it? And Tarek should be putting up the male fertility video, which we're still missing, by the way, very, very shortly. So if you watch those two, you probably get 99% of what you need, because we built them so that people would know what they needed to know. And that female infertility video, I think it has like 18,000 views now. So it's on YouTube. Jump to our YouTube channel, www.youtube.com/drvictory. You'll find it there. It's under the popular uploads. I think it's like this 4th or 5th one or 6th one or something. So check it out there. Female infertility. Tarek will have that male one up right away, because we said it on the show. I think that's it. Is that good? Okay, so I want to give a special thanks to someone very special to me. A couple of people very special to me, actually. So I want to thank my incredible, incredible family, who during a recent holiday had to endure a little bit of a family emergency, or probably more of a bit of a family emergency, and pulled through it with flying colors. In particular, my daughter Jenna is probably one of the most amazing young women I have ever known or met in my entire life. Jenna, I love you. I'm very, very proud of you. You're an incredible young lady. My son Nassim, who is there with us through thick and thin, calm, composed, amazing, my buddy to the end. My incredible, incredible wife, who weathered it all and managed to coordinate everything in a jiff and stick through it all with composure and love and compassion. And my other amazing son, who unfortunately is away up at our cottage. You can find him on Instagram. He posted an awesome picture of himself, which he would not let me repost, but it's Mateen V. So go check him out. And he had to be without us, which has its own level of hardship. So thank you to my incredible family. Love you guys. You're all amazing people. I'm so, so honored to be part of this family. And I'm so proud of all of you. So thank you guys for making a very challenging time a really good time. And I love you all. Thank you for joining us on the show. Throw out some likes for my amazing kids and my amazing wife. So lots of little flying hearts and thumbs up and all that fun stuff. If somebody has a topic they want us to review, I am more than happy to do that, because quite frankly, the research papers that we used to focus on during the show currently suck. So if you have something you want me to review, give us a notice. Tell us on Instagram. or email us or any which way you want and let us know. If you're in the US and you want to come to see us, start emailing info@drvictory.com. We will be able to take American patients very, very soon, and we will be more than happy to bring you in and do what we need to do. Have a great night, guys. Good seeing you again, and look forward to having you back on Fertility Fact or Fiction.